to our second town hall. Today is November 10th, 2022, and we are going to have a town hall today on dermatology, which is an awesome topic and something we get in our offices quite a bit. Before we begin, I just want to take a moment to go over the disclosure slide that we do not have any financial relationship or commercial things to disclose. We are free of all of those things. And I also wanted to just go over a few things. We found out this week that you have to claim your CEUs for the town hall. After each town hall, you have 30 days from the date of the presentation to claim your printed certificate. So for those of you who attended the October 27th, please do that either before Thanksgiving or you have until the 28th, which is Monday after Thanksgiving. So please try to get that done as soon as possible if you attended that. You log into the UVM continuing education site. If you don't have the link, you can actually literally Google UVM continuing education and go to their website and collect credit, and it will take you exactly to the sign in page. You do have to sign in with your email address that is assigned to your VSSNA membership. And you need to select the VSSNA town halls from the drop-down menu in order to get the correct credit. You complete an evaluation and then you can print your certificate. We also found out today, like literally just before this, when I read an email, that you do have to attend the live in-person presentation in order to get CEUs. Watching recorded presentations is a completely different CEU application, and we did not have that type of application. So apologies, we are just now figuring this all out. Please, during the presentation today, put your questions in the chat and our presenters will be answering questions shortly after they're done with their presentation. And without further ado, I will introduce our speakers. Today we have Rebecca Lapides. She's originally from Boston, Massachusetts, and has a background in nutrition science. She worked in nutrition counseling for 1 year before beginning medical school and became interested in dermatology after learning about all the nutrition and GI-related conditions with cutaneous manifestations. She hopes to pursue a career in Mohs surgery. I hope I said that right. And then our second speaker is Simran Kalsi, and she grew up in the UK before moving to the US for college. She completed her BS in biology at George Washington University, her Master's of Science in Biotechnology at Johns Hopkins University, and a medical science post-baccalaureate at University of Vermont before starting medical school at Larner College of Medicine. Prior to medical school, she worked as a clinical research associate in the emergency department of George Washington University Hospital, a medical assistant certified dermatology tech and clinical research coordinator at Derm Associates in the DC metro area, and clinical program coordinator for the emerging infectious diseases branches of the Walter Reed Army Institute of Research during the early stages of the pandemic. Her clinical interests and current areas of research include complex medical dermatology, pediatric dermatology, and improving health equity. Her personal interests include hiking, baking, learning new languages, and event planning. Rebecca and Simran are also currently the co-leaders of the Dermatology Student Interest Group at the College of Medicine. So without further ado, here they are. Thank you so much for being here.
Thank you. I'll go ahead and share my screen. Thank you for that lovely introduction, and thank you so much for having us speak with you today. Able to see my slides there clearly? Great. So as Becca mentioned, Rebecca and I have an interest in dermatology. We're both third-year medical students at the moment, and today we're going to be talking about common pediatric skin conditions. And hopefully by the end of this talk, these images to the left, you should be able to at least have an idea of a few things it could be for each of these pictures. So when we're looking at rashes are really hard. It's really difficult to just look at a rash and know what it is. And so it helps to have an outline or a framework to use when you're evaluating a rash. And this is a really helpful mnemonic, SCRIPTS, which stands for shape, color, region, itchy, painful, trauma-related, and systemic symptoms. These can all give us clues as to the type of rash it is, but it gives us a really nice framework for how to ask the patient questions or the child questions, and whether you're looking at one or more lesions, the kind of pigmentation those lesions have, its pattern of how it comes and goes, or if it's chronic. If it's more itchy, that could suggest more of an allergic process, whereas if it's painful, that could be more inflammatory or infectious. And then when it comes to trauma, this could just be accidental scrapes and accidental trauma, but it's always important to keep in the back of your mind if it's non-accidental. Those can have some significant implications. So just keep that in the back of your mind when you're looking at a rash or a lesion. And systemic symptoms such as fever, joint pains, vision changes, changes in mental status, those could indicate a more severe systemic problem that should be worked up further and potentially seen in the ED or emergency department. And we'll talk a bit more about that towards the end of the presentation. So a starting point to looking at the shape, color, distribution of a rash is to look at the individual lesions. And these are some examples of the type of lesions you might see and some descriptive words for them. It's less important to know how to write out a description for a rash or say out loud a description for a rash, but it is helpful to have these words in your mind as you're looking at the rash or the lesions. And you can divide this up into two main buckets. So we have primary lesions and secondary lesions. I'm going to draw a line here that divides them. On the left, you can see primary lesions, and these are the lesions that are directly caused by the disease. So for example, acne could cause pustules, a herpes infection could cause vesicles. These are things that are directly caused by the disease. And then on the right, we have secondary lesions that typically come up either evolving from the primary lesion or from external forces like scratching, infection, trauma, or the healing process itself. And these would be things like scaling, crusting, which could be secondary to an infection of an eczematous area. Or we could have lichenification, which is these exaggerated lines in the skin due to scratching and thickening of the skin over time with scratching. So these are just some good descriptive words that we'll be referring to throughout the presentation and that are helpful to keep in mind when you're looking at the rash. It's also really important to think about how rashes might look different on different skin tones. For example, on lighter skin tones, what might seem like erythema, also known as redness, could be more purple in tone or violaceous on darker skin tones. And there may be more hyperpigmentation where the affected skin appears darker than the baseline skin tone. To check for erythema, one good tip is to apply some pressure, either with just your finger, or you can use a little slide, a microscope slide, or any glass. Press it on the skin, and if that skin becomes lighter or paler in color, then that's typically erythema. So that's this inflammation and redness or purple tone to the skin. In darker skin tones, it's also important to remember that when you have an area of inflammation, once that inflammation resolves, there may be more hyperpigmentation that's residual and may last longer. So while a child with eczema may have the eczema clear up with treatment, they may still have areas that are more darkly pigmented once that eczema is actually treated. And that can last for months, years even, and can affect kids, social interactions, and psychosocial impact of that is pretty significant. A good way to focus in on what the rash could be is, as I mentioned in the previous slide, looking at these textural changes. So for an example on the screen here, we can see that there's this scaling. It's kind of a silvery scale on this plaque that appears to be pinkish, but there's also these darker tones that could be considered more hyperpigmented or violaceous. And these clues in terms of the texture and the color here would suggest that this is a psoriatic plaque or psoriasis. And so we'll dive into looking at some images of rashes and going into more of the details. I've grouped these according to their similarity. So these are rashes that could be potentially confused for each other in some cases, or have very similar treatments or similar names, but we're going to tease out what the differences are between them and how to identify them more accurately. So beginning with this image on the left here, we can see that there is some darkened areas. We're looking at the back of the knees. And as I mentioned before, there's these exaggerated lines known as lichenification that's usually caused by scratching the areas. And the areas that are affected do seem a bit more thick compared to the surrounding skin. This would be consistent with eczema. Eczema is very common. It's a chronic, relapsing, remitting, very itchy condition. There are some genetic components and some environmental components as to what causes it. Oh, no. Okay. So when you're looking at eczema, it's obviously going to be itchy. It's known as the itch that rashes. In younger children, it can usually be on the face, especially the cheeks, and it may also have some involvement of the knees and elbows, although it can occur anywhere on the body. As they get older, it tends to be in more of the folds of the skin, so behind the knees, inside the elbows, and there's often a strong correlation with the child having allergies, asthma, or a family history of eczema as well. The first line treatment for this would just be to recommend that they use a very bland, fragrance-free emollient or moisturizing cream rather than a lotion. Lotions tend to be more watery and don't hold as much moisture in the skin. So creams are recommended, and ones that don't have any colors or fragrances, especially to avoid irritation. It's also recommended to use very gentle soaps and cleansers, and you can even avoid using dyes and fragrances and laundry detergent too. It's especially important to avoid hot baths and showers in these kids because that can dry out the skin and exacerbate the itching and dryness further. On the right, we have more of these distinct round pinkish plaques that have, again, this silvery scale over it. And this would be more consistent, similar to the previous slide with psoriasis. Psoriasis is also a chronic skin condition. It's caused by this excess growth of the top layer of the skin cells and a lot of inflammation, and there's thought to be some systemic components to psoriasis. So it can even affect the heart as somebody gets older. There's a lot of ongoing research into how psoriasis affects the entire body. There's genetic and environmental components to the cause of psoriasis as well. And it's usually, as I mentioned, presenting as these red or sometimes violaceous or purple scaly plaques with a silvery scale. These thickened areas could be on the body, the face, or the scalp. A good trick to determine if an area is just a crusted over eczematous plaque versus a psoriatic plaque would be to scratch off a little bit of the scale from the plaque. And if you see pinpoint bleeding there, that suggests psoriasis. This is known as Auspitz sign, but basically you would just see little dots of redness that this is psoriasis rather than eczema. With psoriasis, once you've identified it, you would definitely also want to ask the child about their nails. If there's any yellow-brown discoloration of the nails, there could be lifting or pitting of the nails. And ask the child if they're having any joint pains or vision changes, because you want to rule out any associated psoriatic arthritis or uveitis that could be involved. For psoriasis, you really do have to start with a topical steroid. Mid to high potency are recommended as the mainstay of treatment. There are some non-steroidal topical treatments. Tacrolimus is one that's prescription for more sensitive areas of the skin, like the groin or the face. And over-the-counter options would be something like salicylic acid, ketoconazole, or tar. In the olden days, tar was used a lot, but it's not used as much anymore. And in very severe cases, if it's really widespread and really not reacting to any of the topical treatments, that they should be seen by a dermatologist to talk about oral medications and injectable medications, especially if they do have that joint or vision involvement for psoriasis. So next we have two rashes that have very similar names, but different causes and different presentations. On the left, we can see these hypopigmented patches on this child's chest and face. We can see that it's lighter than the surrounding skin. It seems pretty diffuse. They're not very well demarcated here. And this is consistent with a condition known as pityriasis alba. It commonly affects children who are 3 to 16 years old, and especially those children who are prone to allergies, asthma, and eczema, which is known as the atopic triad, as well as children who have generally drier skin. And as I mentioned, it appears as these kind of hypopigmented macules. It could be patches. Typically, it's asymptomatic, but some children may be mildly itchy. And it usually resolves by itself as late adolescent, as the child gets older, or even through adulthood, without any intervention at all, it can go away. There are some things that can exacerbate it, though, such as heat, humidity, sunlight, certain soaps and detergents that are more abrasive, and abrasive clothing can even aggravate the condition. So the best treatment for this would be to start with low to mid potency topical steroids if it is bothersome to the child. So if it's symptomatic, then they could start with something like a hydrocortisone ointment or cream if it's not too widespread and is able to be used in that way. Another option that's prescription would be the tacrolimus. Again, that could be used in more sensitive areas where you want to avoid using steroids to avoid the skin becoming thinner. And it's also really important to remember that children where they have these hypopigmented areas are more prone to sun damage. So they should be really encouraged to apply sunscreen and moisturize very well to keep up their skin barrier. On the right here, we see more of these pink, red papules and plaques. And if you look closely or squint a little bit, you can see that they kind of fall into these lines. And this is known as a Christmas tree pattern. If you were to see the spine as the trunk of the tree and the lesions coming off as kind of the branches coming down. And this is known as pityriasis rosea. It usually begins as a single patch, and it's typically in adolescence. So middle school, high school aged children tend to have it, but it could be seen in younger children as well. And so it begins as this single scaly pink or flesh-colored patch, usually on the back or chest. And in the coming days and weeks, it develops these oval or round pink erythematous plaques and papules in that Christmas tree pattern that I mentioned. Typically, it spares the face, the palms, and the soles. Tends to mostly be on the trunk and the upper extremities when it does come up. And the spots can be completely asymptomatic, or they can be very itchy for some people. This is thought to be caused by either a first infection or a reactivation of the human herpes virus. So no treatment is actually necessary for this rash either. It is self-limited. And so if it is especially itchy, they could take an over-the-counter oral antihistamine. But since it tends to be widespread, it's usually not worth it to apply a large amount of hydrocortisone cream, but an oral antihistamine can take off the edge from the itching. So next, on the left, we have a very common fungal rash. Both of these are fungal infections of the skin. I feel as though people on the call should know what the one on the left is, or may know what the one on the left is if they've seen it before. tends to be this round, scaly plaque. If anyone has an idea, feel free to throw it in the chat. This is something you've seen in clinic. And around the plaque, you might see these little papules here as well. If you were to look closely enough, there would be some scale at the edge of this plaque. And, oh, we have somebody in the chat. Yep, that's it. It's ringworm. So this is also known as tinea corporis, but commonly known as ringworm. And it's caused by a fungal infection by the dermatophyte species. This is typically spread by direct contact, so it tends to be very common in kids who are engaged in sports. It may have a central clearing to it. It may have little vesicles or fluid-filled spots or papules at the edge, but usually has more scale at the edge. It can be very itchy, and as with psoriasis, lighter skin tones may have it appear more pink, red, and darker skin tones, it may seem more purple or grayish. So it's important to avoid topical steroids for ringworm because that could actually worsen the condition. For fungal infections, you want to avoid steroids entirely. Instead, you want to focus on a topical antifungal cream such as clotrimazole, ketoconazole, econazole, most of which are available over the counter. So they may be marketed as for athlete's foot, but they can be used if there's a small area of ringworm on other parts of the body. And they can start with that and see if that helps. It tends to help pretty quickly. On the right here, we see more of a widespread fungal infection. This is on the child's back. These are hypopigmented macules and thin plaques or patches. If you were to look closely enough, they would be very finely scaly. And as you can see, they're just much lighter than the baseline skin tone. This is known as tinea or pityriasis versicolor. It's more commonly known as tinea versicolor. And this is a very common, benign, superficial fungal infection caused by a yeast known as Malassezia. As I said, it usually is very widespread. There's usually macules, papules, patches, plaques, different types of pigmentation, but usually hypopigmented, so usually lighter than the surrounding skin. And it can come up on the trunk, on the arms, on the neck, on the face. It's usually asymptomatic and is not contagious. That tends to be a common question that's asked when a patient comes in with this, is it appears contagious, but it is not contagious. It responds very well to topical antifungals, but if it is extremely widespread and not responding to topicals, they may need an oral antifungal medication. In that case, they could be referred to their primary care or their dermatologist. The skin changes that happen, because they are pigmentary changes in tinea versicolor, it can take months for it to resolve after the rash is treated, and it can recur pretty commonly. One tip that's given to kids who are athletes is to make sure that once they are done sweating and exercising, to take off those sweaty clothing and make sure you shower well to remove any risk of, or reduce the risk of recurrence with tinea versicolor. So next we have another two lesions that are very common in kids and often confused for each other. I'm sure people on the call would know what the one on the left is. This is a pretty severe case of them, but if you have a guess, feel free to drop it in the chat. Yep, that's it. It's just the common warts. You got it. So verruca vulgaris is the scientific name for it, but it is the common wart caused by HPV types 1 to 4, very prevalent in children, and they usually present as these kind of thickened or cauliflower-like papules and nodules, and that could be on the hands, fingers, elbows, knees. They can be itchy, but if scratching can actually cause it to spread to other areas. The best treatment for this then is to pare it down with a scalpel blade. So you shave off those top thickened layers of the skin and freeze it at the base with liquid nitrogen. That's the best first line treatment, but pain tends to be the limiting factor. As you can imagine, kids probably don't want to have that treatment done. And it typically takes multiple sessions, at least 3 or 4 sessions for them to really go away. So there are other options available. Something known as cantharidine or beetle juice is what we tell the children in clinic, is a liquid that's applied topically to the areas, and that can cause blistering over a few days, and then the wart should go away. Again, that might require a couple of treatments for it to fully go away. But these are really stubborn. So there are more, severe conditions of warts where they have multiple warts coming together to form a larger plaque. And in those cases, it would be recommended to refer them to dermatology, where they can use things like a topical chemotherapy cream, intralesional injections to get rid of them, or even lasers. Then on the right, we have these conditions, these lesions that look like little dome-shaped papules, and it looks like they have little openings in the center, so little depressions known as umbilication. These are also caused by a virus, but these are caused by the pox virus. So this is basically the chicken pox of the current generation, since they are vaccinated against chicken pox. It is spread by direct contact between children, and it usually has this central umbilication and can occur anywhere on the body. So that's really the defining feature of it. It tends to be more common in children with eczema, or if they are immunosuppressed, since they're just more susceptible to infection. And it can also be very common in children who are swimmers, since they're often sharing towels. The course of these lesions is very self-limited, so you don't have to do anything for them. But if it is bothersome, it tends to be more bothersome to parents than to the children, but they can be treated with the same thing as the common wart, the cantharidine or beetle juice, or cryotherapy, so just freezing them if needed. I'm sorry, I should have just shown you those options there. But on the next slide, we have possibly the most common condition seen in young children moving through puberty, and that's acne. Very common, as you can see, there's lots of pustules and erythematous papules there. It's caused by those increase in androgens as they move through puberty, and that causes an increase in sebum production in the skin and proliferation of a specific bacterium in the skin that causes inflammation. It can be very varied in presentation, as I'm sure you know. It can have whiteheads, more cystic components to it that are more painful, usually on the face, back, or upper chest. Tends to be self-resolving, so by late adolescence or early adulthood, most people will grow out of acne, but it can persist for some and might require more aggressive treatment, especially if it's the cystic kind or very severe and widespread. To avoid permanent scarring, it's really recommended to get them to a dermatologist as soon as possible. For milder cases, you can always start them with an over-the-counter benzoyl peroxide, which could be in the form of a cream or gel, or even a face wash, and use that along with a topical antibiotic or a retinoid, depending on how severe it is. It's really essential to remind the child that they don't need a whole array of expensive skin products that are filled with active ingredients. Really, the best thing to do is use a gentle cleanser, gentle moisturizer, and sunscreen every day to avoid the residual scarring after the acne has resolved. On the right here is another condition that's similar to acne. Actually, it's thought to be protective in some cases for acne in older age. And this can occur in any age person, but it actually is, it can be, it's known as keratosis pilaris, which is also known as chicken skin more colloquially. It happens in about 2/3 of people. It's very benign. It appears as these kind of follicular base. So in the hair follicles, you see these kind of darkened areas, the tiny dots, and on the back of the arms, on the back of the thighs, on the back itself. And it just happens from keratin retention in these follicles. So nothing needs to be done about this rash or this condition. It's just a natural variant of the skin, but it can be a little itchy in some children. It can be more common in children who do have eczema already or asthma and allergies. And if it is symptomatic, the best treatment would be an over-the-counter salicylic acid or lactic acid, which could be something like amlactin cream, and gentle exfoliation in the shower with a loofah, along with moisturizing well, just to improve that texture. And so now I'll pass it on to Rebecca, who's going to talk more about what happens when you see a fever with a rash.
Excellent. Thank you, Simran. So next we're going to move on, talk about fever and rash together. So usually a lot of the rashes that Simran just talked about aren't accompanied by a systemic illness or inflammatory process, but some skin changes are. So the first one on the far left, as you can see, is the chicken pox. This might be the most familiar for most of you. So the chicken pox is caused by varicella zoster virus. So this is a viral infection. And this is really characterized by an itchy rash with small fluid-filled blisters, okay? And while those pockets are full of fluid, it is highly contagious. Okay, now this rash tends to occur in multiple stages. So the first stage, you see raised pink or reddish bumps or papules, which can break out over the course of several days. And then the second stage is that they become these fluid-filled blisters or vesicles, which form in about 1 day, and then they break open and leak. Okay, and then the third phase is where you see these lesions start to crust over and scab, and this covers those broken blisters, and they will take several more days to heal. So the key to identifying this rash is that you have new bumps that continue to appear for several days. So you can have all 3 stages of the rash, so the blisters and the scabbed lesions and the vesicles all present at the same time. So that's the key here to identifying the chicken pox, is looking for lesions in multiple stages of healing. Okay. Of course, we have the varicella vaccine now. So vaccination status is going to be really important, asking children and parents about vaccination status to see if the kids have received their vaccines. All right. Moving on over, we have the measles next. So measles is also known as rubeola. This is also caused by a virus. Okay, so this rash looks a little bit different. It's made up of small red spots, some of which might be slightly raised. You can kind of see in the image there, there's might be a little bit of texture to some of them. And they form in tight clusters that give the skin kind of a splotchy red appearance. Okay, and the pattern of the rash development is important here with measles. So the face tends to break out first, and then the rash will spread down the arms, the chest, back, and then even sometimes can continue on down to the lower extremities over the following several days. So this is often accompanied by a very, very high fever. So children with measles can have fevers up to 103, 104, and that's really, you know, a ticket to the hospital right there. So they would be in the hospital at that point. But the rash itself lasts about 7 days, so about a week, and gradually resolves again from the face first, and then progressing its way down to the thighs and eventually to the feet. Okay, it's also not uncommon with the measles that you may have some darkening or peeling of the skin where the rash was, and that can persist for about 10 days even after the rash resolves. Okay, so those are skin changes to look out for as well. All right, and then we have rubella. So rubella is also known as German measles, not to be confused with measles that we just talked about. All right, this is also a viral infection. So similar to measles, the rash starts on the face as sort of a pink rash with small raised lesions that spreads downwards onto the torso, the arms, the legs. And as the rash is migrating downwards, the areas where the rash initially came up on the face will start to clear up. This is also accompanied by a fever. So this can look pretty similar to measles, but usually with rubella, the rash tends to last for about 3 to 5 days. So timeline is really important with these two rashes here and helping to differentiate them. You want to know when the rash started and how long it's been persisting. Of course, we have the MMR vaccine as well. So again, vaccination status is very, very important to ask children and their parents in helping to discern what the diagnosis is here. And then on the far right, we have erythema infectiosum, also known as parvovirus B19 or fifth disease. Another sort of explanation or name that you might hear is slapped cheek for this virus here, because it has a characteristic red rash that occurs on the cheeks, and it's really concentrated, as you can see in the pictures on the face. Where it occurs on the face is really concentrated on the cheeks. Okay, so it's very erythematous or red. It has this lacy pattern, so you can see that some areas have more redness and some of the areas look more pink, and it sort of gives this lacy appearance to the rash. You can also find it on other areas, so it may occur on the trunk and the limbs as well, but it doesn't occur as widespread as measles and rubella. So measles and rubella, you'll kind of see these sort of larger skin changes over greater surface area, whereas with parvovirus, it's not as widespread there. So this is a very, very common virus in daycares or where young children are around each other in close proximity, and it is contagious in that way, but usually doesn't have any lasting negative effects on the children. Right. So this next one, I think, is one that might be familiar to a lot of you. So this one is Lyme disease. And this is something that we think about a lot being in the Northeast. This is one of the hot spots for Lyme disease. So in other areas of the country, they might not see as many cases of Lyme disease, but we do tend to see a lot here. I've seen several down here in Connecticut since being here for my rotations. So this rash is the classic bullseye or targetoid type rash that you might hear people talking about, where it has this sort of bullseye in the center with this central clearing and then some surrounding erythema or redness that gives it this characteristic bullseye look. So this rash is going to appear as a red macule or maybe a thin plaque at the site of a tick bite. So it might have a little bit of a raised texture, but usually it is pretty flat. And of course, if the tick bite is somewhere where the patient can see, then they might notice it, but it's not uncommon for ticks to bite on the backs of the legs or the back on the patient's back. So they might not see. If a parent sees, then they can give you that history. But I've also seen a lot of cases of Lyme disease where the tick actually bit in the scalp. So the rash was totally covered by the patient's hair. And so nobody ever noticed a skin rash. And that makes Lyme disease a little bit more difficult to diagnose. Typically, right, once you see this targetoid rash, then you know it's Lyme disease. But if you have sort of these nonspecific symptoms and never saw the rash, it's more difficult to diagnose with Lyme disease. Okay. And then always keeping in mind as well what this redness might look like in different skin tones, right? So in a sort of a deeper skin tone, the redness might seem more of like a deep red or a maroon color, okay, as opposed to that bright erythematous red that we tend to see on the lighter skin tones. The treatment here is oral antibiotics for 2 to 3 weeks. It's important to keep in mind that first line for Lyme disease is doxycycline. This is a tetracycline antibiotic, and it's not recommended for young children because it actually deposits in bones and impairs bone mineralization. So in children under 12, you actually wouldn't want to use doxycycline. Azithromycin is a good second-line treatment. So I've seen that used in a lot of children, and it's also good because it covers other secondary tick-borne illnesses like babesia. So it will cover both of those infections. All right. And then this might be a little bit unfamiliar for some of you, but I wanted to include it because I actually did see several cases on my pediatrics rotation. So this is called erythema nodosum. This is characterized by tender, red, and inflamed nodules. They're usually found on the anterior or front surfaces of the shins, and they're usually symmetric. So the key here is that these nodules are exquisitely painful. Okay, so in the patients that I've seen with erythema nodosum, they can't even lie in bed with the sheet over their legs because the weight of the sheet on their legs causes so much pain that they have to lie on top of the sheets. They can't take a shower because the pain of the water hitting their skin on their legs is so severe. So these nodules are exquisitely painful, and sometimes they can even look like bruises. Okay, so you want to get a really good history from the parents as well and from the patient, because you can see in the image, right? Sometimes if you don't have so many of them, like you see in the image on the screen, you might mistake it for bruising. Okay, so we want to make sure that we have the correct history there. What's significant about making sure you don't miss this diagnosis is because there's usually an underlying inflammatory condition. Okay, so in a lot of children, we can see erythema nodosum come up from IBD, inflammatory bowel disease. So I've seen a lot of the kids that I've seen with this have urgent GI referrals, and they're subsequently diagnosed with Crohn's disease or ulcerative colitis. Okay, sometimes erythema nodosum is the first sort of clue. So not all the time will a child have GI symptoms that might suggest inflammatory bowel disease. So you want to be hypervigilant about that. Can also occur with sarcoidosis, which is a lung condition. So you want to ask about respiratory conditions and difficulty breathing. Strep infections, so strep throat. I've also seen erythema nodosum happen as a result of a strep infection in a kiddo. And strep infections are common in young kids, so we want to look out for that. And tuberculosis as well, so always making sure you take a good travel history to see if that might be a possibility. I've even seen erythema nodosum happen as a result of young female adolescents starting oral birth control pills. So the combined estrogen and progestin birth control pills I've also seen be a trigger for erythema nodosum as well. So the key here is that this is caused by the inflammation in the body. So this is a secondary condition. So it won't go away unless you treat the underlying condition. So as sort of a quick fix, while there's a diagnostic workup happening, you can give prednisone, which is a steroid, and that will usually take care of the inflammation such that the lesions will become less painful and more bearable for the child. But you always, prednisone and steroids, oral steroids, they are not long-term drugs that anybody should be on. So there always needs to be a secondary diagnostic workup happening so that you can establish the accurate underlying diagnosis and treat that effectively. All right. So when to refer to the ED. So of course, petechiae or purpura. So this is like bruising or really small pinpoint red spots that you can see on the skin, accompanied by a fever. Okay. And so, a lot of the skin changes that Simran talked about are obviously just kind of cutaneous or skin related. But if you have something underlying that suggests there might be a systemic problem, inflammation, fever, other symptoms, that's a reason to consider being evaluated in the ED. Also, if you have shock that accompanies the rash, right? And shock is low blood pressure, right? And that's usually accompanied by an increased heart rate to hopefully sustain organ perfusion so that the organs get enough blood and oxygen. But when shock sometimes becomes too severe, it's not really responsive to fluids, and it can be extremely dangerous and life-threatening. So this is also definitely a reason to be evaluated. Also, a lot of derm conditions are itchy. So, someone might complain of itching or some sort of superficial discomfort, but pain is really, really alarming. So somebody has a skin rash with pain, especially pain out of proportion to what you see. Usually that's an indication that there's, a concerning underlying infection that needs to be evaluated. All right. And then, of course, if you have signs of anaphylaxis, which is a life-threatening allergic reaction, so swelling, difficulty with breathing, urticaria or hives, right, that sort of come on abruptly and break out all over the body, this is definitely a reason to go to the emergency department. Treatment for this would be epinephrine. And then, of course, like Simran mentioned at the beginning, is always sort of keeping in the back of your mind, especially when you're dealing with younger children that can't advocate for themselves as well, if the rash or a skin change might be consistent with possible non-accidental trauma. So is there bruising that's, in different stages of healing? Is the mechanism of injury that the parent describes to you consistent with the age of that child? Is it consistent with the injury? Are there potential burn marks? Is the child injured in places where the child can't really reach on their own? So these are all considerations when you're doing an evaluation as well. All right, so then we have some additional tools and resources for you. So the AAD.org curriculum has some videos and some courses. The basic dermatology ones, I believe, are free to take. So you can investigate those for more information and sort of can help give you more of the basics of dermatology there. And then also the ASA, I hope I'm saying that correctly, but I love the ASA mobile app. So this is an app that you can use to take a picture of a skin change, either on yourself or on someone else. And then it will compare that picture with the database of pictures in the app and also ask you other questions about the rash, like when it came, if there's itching, if there's pain, and help to give you a differential diagnosis or a list of what it could be to help you sort of discern what the diagnosis might be. So these are some excellent tools and resources for you to look into if you want more information. And thanks so much for your attention. And I think Simran and I are happy to take questions.
If anyone has any questions, you can put them in the chat. There's one question that just got put in the chat. Can you guys talk a little bit about hand, foot, and mouth?
Yeah, what kind of questions do you have about hand, foot, and mouth?
So the reason I put it in there, we've seen an increased amount of that. And the last few cases that I've seen hasn't just been on the palms of the hands, of the base of the feet, or inside the mouth. It's been on the cheeks, on the arms, on the shins. It just seems like it is more involved. I didn't know if that's something new.
I'm not sure about that. I'm not sure if, Rebecca, you have any insight into the variants of hand, foot, and mouth, but what we could do is, if not, we can always speak to Dr. Morley and see if he has more insight into how that's changing over time.
Yeah, I haven't seen a presentation like that. I think it would be atypical, but certainly not impossible.
And I see there's a question in the chat about a picture of impetigo. So I'm just pulling one up here for you. So impetigo typically being characterized by those honey crusted plaques. And I can share my screen here to show you some example images. These are quite severe cases, but let me show you what I have here. And this is another great resource actually for dermatology. It's known as dermnetnz.org. It gives a really brief overview of conditions and some example images. So here are some images of those honey crusted plaques. It tends to be on areas that are affected by eczema or have some underlying break in the skin barrier. And it tends to be a staph infection. Any other questions? I would love to hear what you see commonly in the clinic, and what you still have questions about.
I have a quick question about, since COVID, we've been seeing a lot of more respiratory illnesses when masks came off because kids weren't interacting in the same way. I'm wondering if there's any, like obviously hand, foot, and mouth we're seeing more of, but are there any other dermatology related things that we should be on the lookout for because of the increased interaction among children who weren't interacting prior to COVID? I mean, not prior, but during COVID?
Yeah, that's a really great question. A lot of the things that we mentioned in the talk that are caused by direct contact, like tinea corporis or molluscum contagiosum, would be more common. For slightly older kids, they may have more issues with acne and hyperpigmentation from acne due to mask wearing. And in terms of viral infections, viral rashes can always look so different. But if you see a very widespread rash, it would be important to kind of tease out what other systemic symptoms they're having. And I'm not sure, Rebecca, if you have anything else to add to that.
Yeah, that's pretty much it, Simran. Anything that's contagious that you see from contact, because now we see a lot of barrier-free contact between children, that's going to be increased a lot.
Yeah, one thing with the viral rashes to be aware of as well is the extremely high temperatures and any other systemic symptoms that would indicate more Kawasaki. COVID especially has been associated with Kawasaki or MIS, which is an inflammatory condition that can affect multiple organs in the body. So if it seems like they're really rapidly having this widespread rash and rapidly having systemic symptoms, it would be important for them to be seen and worked up for something like Kawasaki disease.
There's a question in the chat. What is dyshydrotic eczema?
Yeah, so dyshydrotic eczema, Rebecca, did you want to take this or I can go ahead?
Yeah, go ahead.
Okay, so dyshydrotic eczema is more of a variant of eczema. It tends to be more vesicular, so there's fluid-filled little vesicles that often come up on the hands and the fingers, can be triggered by stress at times as well. So it can either be direct abrasion or irritation with chemicals, or it can just be from stress as well that can cause these to come up. Did you have any other specific questions about dyshydrotic eczema? It tends to respond similarly to eczema on other areas of the body to topical steroids.
So we have a case study
Yeah,
in the chat. An African-American child who is new to my school has nose, upper lip bumps, not blistered, that come and go. Mom says for months, not itchy. They're about the size of a regular wart. Any thoughts?
Interesting.
Probably hard without seeing it.
Yeah, a little difficult without seeing it.
Know what color they are? Skin tone. It makes me think of molluscum contagiosum that you were talking about, Simran.
Yeah, it could be molluscum, could be HSV in rare cases, could also just be nevi, regular moles, not symptomatic, and they've just been present for years. It's also really common for kids to develop new moles as they get older, all the way up to your 20s even. It could possibly be if the child is growing, if they're further into puberty and they're growing hairs in that area, it could be.
Yeah, how old is that child? 10, okay.
Yeah, I think for ingrown hairs, it might be a little bit more irritated, a bit more painful, tender.
It sounds like a dermatology referral to me. Any other questions or case studies you guys want to discuss? Well, this has just been amazing. And I have learned so much in this presentation. I am so thankful for dermatologists out there because we get the number one question. Can you look at this? What is it? Is like the number one thing that we're asked. And I'm wondering if anyone has any questions, that you can raise your hand and just unmute and ask it yourself. I'll give you one last chance to ask any questions.
Or any interesting experiences that you might have had with kids coming into the clinic with interesting rashes and how you worked those up or what you did for them. That would always be useful to hear. We'd love to learn from you too.
This is Terry Shaw from the Georgia School. I just wanted to share something about a preschooler who they were sure that it was ringworm, but he was in preschool and he had just been sucking his arm. So, we have to take all those things into account. Thanks, this was awesome.
Thank you.
Clayton, your hand is up.
So I had a young child, a sibling, 2-year-old. The dad called and said, "I think my child has chickenpox." So the other preschooler, I said, "Why don't we have him go home until we figure out what it is?" And when he brought the 2-year-old in, it looked like it was only on legs and arms and cheeks, and it looked more like hand, foot, and mouth than it did chickenpox because it wasn't on the trunk or anything. Went to the doctor. The doctor said they think it is hand, foot, and mouth. Let's watch and see. It resolved within like 10 hours. And it was completely gone. And so the question becomes, I don't think hand, foot, and mouth can clear up that quickly. So could it have been just contact dermatitis? Something that had to do with that. It was really weird because it was kind of like first thing in the morning. We were trying to protect the other kids just in case. But then it was gone almost immediately. And I don't know if you've seen anything like that or have read, but I guess it could have just been contact dermatitis.
It sounds like it's probably an allergic process. I'm not sure if they ate something differently than usual, but for it to resolve in that timeline, that's usually something, like you said, either a direct contact or just an allergic reaction to something, especially if it's in and around the mouth.
Another question in the chat. Can you speak a bit to strep-related rashes?
I'm not sure if you read about that during your research, Rebecca.
Yeah, I can talk a little bit about that. So strep throat is the most common strep infection that children will get. And what you worry about the most with strep throat is actually a heart disease and kidney issues as well. So not really skin related. I had mentioned that erythema nodosum, which is also known to occur after strep infections. But then also children that have superficial abrasions or cuts on the skin, staph and strep are part of your normal skin flora. So you can actually get cellulitis or erysipelas, which is a more superficial skin infection than cellulitis. And those are often caused by the streptococcus bacteria. Those often require oral antibiotics to heal.
How would you identify that?
The cellulitis?
No, that it's a strep infection of the skin.
Yeah, so if there's a little bit of an opening on the skin with some sort of purulent material draining out of it, you can take a culture of it and see what bacteria grows. But usually, because cellulitis is just so often caused by staph and strep species, you'll treat it empirically with an antibiotic that covers those bugs. And then if it goes away on its own, then that's usually what it was.
Any other questions or case study related topics? What would you guys leave us with as your last comment as a third-year medical student in dermatology? The number one thing a school nurse should know about dermatology.
I would say try to look at as many images of a specific type of rash as you can to really get to know the variants of it, how it looks on different skin tones. And then the more you see it, the more familiar you can become with it, and you can diagnose it just by looking at it eventually.
Yeah, that's great advice. I think I would say, especially when you're dealing with young school-age children, think outside the box. For example, we had a child come in with this sort of strange dark rash that they kept having on their arms and legs, and nobody could figure out what it was. And then the pediatrician took a wet cloth and wiped it off. It was dirt. So just always think outside the box when you're dealing with kids.
Well, thank you so much for all the wisdom you've shared with us today. And this is one of those topics that is just always on our brains. Like, we need to know more about this. So thank you for taking the time to come and speak with us today. We really appreciate it. Our next town hall will be December 8th, and we will be talking about asthma. Dr. Cowan will be here to present. It starts at 4 o'clock on December 8th. And please remember to get your certificate from the UVM continuing education website for today's presentation before December 10th, so that you can get your credits for being here today. So thank you so much. Have a great night.
Thank you.
Thanks, everyone.